Welcome to Pomegranate Health, a podcast about the culture of medicine. Steve, can you introduce yourself for us, please?
I can, yes. My name's Steve. I'm an intensive care specialist in Melbourne. I work across a couple of sites at Alfred Hospital and Cabrini Hospital. My other role is in communication training for healthcare staff, so I facilitate the program for the College of Intensive Care. I work for Donate Life, the Organ and Tissue Authority, and I do a little bit of communication training for Monash University undergraduate medical students.
Sounds like you should have my job.
I'm not coveting your job, it's okay.
So you got in touch with us after hearing the last episode, coming back from burnout. And you've got your own sort of remedy for workplace tension to share.
It really resonated with me a lot. I think we've all experienced burnout at times, and through the communication training workshops that I do, people often ask me about tips for staying well in the work that we do, and this is, I think, probably my number one tip now that I give to people when they ask me that question.
Yeah, so go ahead, tell us how it began.
So I remember looking after a patient who had had very complex neurosurgery, posterior fossa tumour surgery, and it was high risk. Everyone was aware that this was a high risk procedure, and unfortunately it was complicated. The patient had bleeding intraoperatively and ended up having an unsurvivable outcome from the surgery. And the patient came to us in intensive care post-op, really for end-of-life care. The family were well supported by our team in ICU. The patient had, I think, the best possible death we could have provided in those circumstances. About a week later, I got a phone call from the neurosurgeon out of the blue. I was on a ward round at the time. And the neurosurgeon essentially said, I'm just calling to say thanks for helping to look after that patient last week. And that was it. It was just to say thank you. And I turned to my registrars and I said, I just had the weirdest phone call from one of the surgeons. And we talked about it. And I remember then sort of reflecting on it, thinking, well, it was actually a really nice phone call, obviously. And in ICU, often we are called on to help with patient management, and why don't more people phone us to say thanks?
Is there some aspect to it where people don't want to admit the intensity of it, that it's just a job and everyone's just doing their job and no one's struggling any harder than they need to? Does that make sense?
Yeah, I mean, I think it is our job to help patients who need to come to intensive care, so I don't expect people to bow down in front of us and and thank us profusely every time we do our job. But I think the reflection for me was just how nice it was to receive that out of the blue phone call. It prompted me to then think about my own practice, and I recognised pretty quickly that I never phone people to thank them either when they help us out. And that's not uncommon in ICU. We're often asking surgeons to come and see patients in the middle of the night, or, we get helped by lots of people throughout the hospital. So I reflected on that and I thought, well, maybe I should do the same. Maybe I should pay this favour forward. And a few days later, we had a patient who came in with an obstructed pyelonephritis and acute renal failure. And for memory, their creatinine was in the several hundreds, and they were very unwell. And we called an interventional radiologist in the middle of the night. It was about 2:00 in the morning. They came in and did a percutaneous nephrostomy tube. And the next morning when I saw the patient, they were making urine, their creatinine was trending down, and their sepsis was coming under control. And by the next day, they were discharged from ICU without needing dialysis, and essentially fully recovered. And so I thought, all right, I'll try this out. And I called the interventional radiologist a couple of days later, and I said, just wanted to thank you for coming in the middle of the night. Because you did that patient didn't need dialysis. They've done really well, and they've gone out to the ward. And I could almost hear the radiologist having the same reaction that I'd had when the neurosurgeon called me, like, what is this phone call all about? And then I hung up the phone and I realised how good it had made me feel to make that phone call. And So I've made it part of my practice now. Whenever I do a run of clinical shifts, we usually do 3 or 4 shifts in a row. At the end of a run of a clinical shift, I will call at least one person that's helped me in some way and thank them. And it's been fantastic for my own sense of well-being in the work. It gives me such a buzz when I make that phone call. And I do hope that ultimately we might improve the culture in our hospital.
Is the camaraderie within your team already quite strong?
I would say it is. I think the hospital system that I work in generally is free of conflict. And one thing I have noticed, though, is when I call specialists outside of ICU, they have a bit of a Pavlovian response to seeing my name come up on their phone. I called one of the general surgeons, and they literally answered the phone with "Uh-oh, what's happening?" And it's because I'm usually calling them because I need their help in an emergency, or actually quite commonly because I want to initiate a conversation with them about limiting treatment or withdrawing treatment from one of their patients. Mm. And so it got to the point where every time I was calling them, it was for a bad reason. Whereas now when my name flashes up on their phone, it doesn't necessarily mean that I want to have a conversation that they're dreading. And I think that's been really useful as well.
Yeah, I mean, does it happen quite often that if you call in the interventional radiologist or cardiologist or whatever, and then they do their bit and then they leave, they might never hear about that patient again, correct?
Absolutely. And we're the same. We discharge patients from ICU. I don't know where they are 6 months later. But if someone called me and said, "Hey, you remember that guy you looked after? I just saw them in clinic. They look fantastic." That would be such a great phone call to receive. And I think it just builds a culture of camaraderie, as you say, and teamwork.
And again, I mean, might be just part of the job that you do your bit. You're there with the patient for an hour and then they're not your responsibility anymore. But if you constantly sort of dehumanize it all, it's all just process work. Do you miss some of the reward of the job when you don't hear what happened to that patient or how colleagues are doing?
Yeah, I think that's right. I think our work can become very transactional and very service provision kind of oriented, and that is dehumanizing. I think also we don't tend to give each other feedback in the work sense, particularly when things have just been routine, When you attend a Met call on the ward and it just runs as all Met calls do, there's never any feedback that results from that. And so another example of this feedback is, particularly after a code blue, a cardiac arrest, I'll often go back up to the ward a couple of hours later and just say, you guys did a great job, and the teamwork was terrific. This is what's happened to the patient, and just close the loop and give a bit of positive reinforcement for people who are just doing their job. And yet it's an extraordinary job that we do. Some of the things we do are much more than just a job, really, when you think about it.
Well, thanks, Steve, for reaching out. Really appreciate the email, and it's nice to hear a positive message at this time when every day there are quite bleak headlines about the pressure that the system is under.
I guess the thing that I hope people think about is that this is just a really simple thing that you can very easily implement into your workplace, partly for team building and relationship building, but also for your own personal well-being. It really has made me feel much more connected at work, and I think it's going to protect me from burning out again with any luck.
You can email us, like Steve Philpot did, via the address podcast@racp.edu.au. It's always great to receive feedback and ideas on making the show better. Original content will be a little slower over the next few months as I take some time out to look after a screaming infant, but you'll still hear outstanding seminars and podcasts from RACP physicians and other medical minds. Continuing on the theme of workplace culture and personal mindset, I want to go back to a session from last year's RACP Congress. It was co-hosted by paediatric emergency physician Sarah Dalton, who we briefly heard from in the last episode. Sarah Dalton has had a career-long interest in clinical leadership, with a Fulbright scholarship in the area, and a term as president of the RACP Paediatric and Child Health Division. She's currently Director of Clinical Engagement at eHealth New South Wales and shares her insights with other health practitioners needing career advice. At Congress, she joined GP Ashe Coxon for a demonstration of professional coaching. Contrary to what many people imagine, it isn't about remediation for underperformance. It's about helping people bring their best to the workplace in a way that's sustainable over the long term.
So my name's Dr. Ashe Coxon. I'm a general practitioner, a career development practitioner, and I work as a Deputy Director of Clinical Training at the Townsville Hospital as well. I am the founder and director of medical career planning, and I've been doing that for about 5 or 6 years now. And I'm also one of the administrators of Creative Careers in Medicine, which is a large, very supportive network for doctors who are considering non-traditional or creative ways of going about their medical career. Probably the main thing that I do, and I've worked with over 600 doctors over the last few years, is talking to lots of doctors who aren't sure if medicine is the right thing for them anymore, or aren't sure if they're heading down the right direction in medicine, or a lot of the time they want to leave medicine and they want to talk about the best methods of going about that. So what I tend to spend a lot of time doing is talking about the reasons behind that decision and unpacking why they might not be particularly enjoying their career at that time. But how did I get here? I guess I got here based on my own journey, and I was a very enthusiastic, inspired, excited medical student all these years ago, just knowing that medicine was just going to be everything I've ever dreamed it would be, that I was just going to be so happy and I was going to help people, because that's why I got into medicine. I got into help people, but I also got into medicine to have a pretty fulfilling professional career. So junior doctor years came around and I sure was helping lots and lots of people nonstop, much to my detriment at times. And I felt like all I was doing was helping people. And I often wondered if I was actually enjoying my job and where that enjoyment in my own professional career was. And I realized that I wasn't. And I thought, well, the solution is obvious. I'm in a hospital. So obviously hospital medicine's not for me. I should be a GP. So I did my general practice training. And you know what? I really enjoyed my general practice training and I really loved being a GP. But as I was going through the process of training as a GP, I thought, here I am spending so much time training to be a doctor, so much energy, so much money, so much study time, and I don't really like my job. And at that stage, it was very difficult for me to open up to anyone and say, do you know what? I don't really like my job. But I decided to start saying to people, I don't really know if I like medicine as much as I thought I would. Like, I thought this would be everything, and I certainly enjoy many parts of it, but it's not everything for me. What do I do? Do I have to leave? Do I have to go back and find another career? And what I found is that the more I spoke about it, the more doctors said to me, oh, well, actually, secretly, I don't know if I love it either. And I went through this process of thinking, well, if there's many of us that don't know if we love medicine, or many of us that aren't particularly happy in our career, why isn't there anyone out there to speak to about us? And so I did a lot of investigating about who there was. And I found the London Deanery that did career coaching and career counselling for doctors, had been doing it for many years and had a very successful program. So I thought, that's what I'm going to do. There's a difference between a job and a career, right? You've got your job, which you go to day in, day out. And then you've got your career, which is a long-term thing that you're working on. And if you're not careful, you can kind of muddle the two in together. If you start not enjoying your job, sometimes you start to think, well, maybe I don't enjoy my career, so therefore maybe I should leave, instead of actually compartmentalizing what your issue actually is and then working on that. So the 5 simple questions I love to ask: what do I like about my job? What don't I like about my job? What do I like about medicine? What don't I like about medicine? And what can I do about it? You might realize that actually I don't like running late. I don't like that particular nurse unit manager I'm working with, and I really don't like managing conflict. Once you've established those key things, what you do and you don't like, you can then move into your day knowing, hold on, I've identified I don't like conflict. I know I'm going to have a difficult conversation coming up with the patient and their family. I'm going to go into that knowing that this probably isn't going to be the most amazing 15 minutes of my life. But at the end, it's over and I move on with my day. That doesn't mean that I don't enjoy my career, because there's many things in medicine we don't like. And I think it's really important to then say, what can I do about it? Is this big enough for me to actually move hospitals or move units or move careers or give up medicine? Or is it something that's modifiable? I'm really struggling with exams. Well, that's going to get better. I don't like this nurse unit manager. Well, I'm going to move on to another rotation. How long am I happy to put up with it? Or is there something I can do to change my own situation? If it's non-modifiable and I can't change anything about the situation, am I willing to stay here, or do I need to go and pursue a different direction? Interestingly, when I got into career development work, I really thought I was just going to be talking to interns and junior doctors about them not enjoying medicine. But in actual fact, majority of the people I work with are senior registrars and new fellows. Because as you probably all know, it's that transition period which can be really difficult. So transitioning from a senior registrar to a new consultant, there are so many things that are changing at that time in people's life. So when you're coming up to a period in your life where you are going to go through a big transition at work, perhaps be prepared that it might start bringing up some questions in you. And then you can go back to my little exercise and say, well, what do I like about work? And focus on that. So Sarah and I are briefly going to go through a bit of a coaching conversation and show you guys how it might work. I'm the coach. Sarah's the coachee. Sarah's a 47-year-old paediatrician who's booked an appointment, wanting to leave medicine and knowing what non-medical career options to pursue. She works at a public hospital, and this is what she's written to me when she's booked the appointment. She's got a good reputation in the community, and she used to love her career, but now she's feeling overwhelmed and no longer enjoying it. And she wants to discuss alternative options about moving out of medicine. Hi, Sarah. How are you going?
Hi, Ashe. I'm okay.
Thanks for booking in today. So I know that you haven't been enjoying work and that you are particularly interested in thinking about leaving medicine or what other options might be out there for you. Are you able to tell me a bit more about that, about why perhaps you're not particularly enjoying work at the moment?
Oh, gosh, I just really don't know where to start because I love seeing patients and I really enjoy being able to help them and understand them, and being a paediatrician and watching them grow up and their brothers and sisters. I love being able to give care to the whole family, but it's just too stressful. My clinics are absolutely back to back and I can't give them the care that they want. There's always someone asking me to do another quick referral, and can I quickly just pop someone in the clinic? And so I end up working to my breaks and running late for other things, and I've just ended up taking so much work home. I'm not up for it, you know. I did this partly because I really care about being a holistic person and to care for people, and I just can't give that care to my patients. I just feel like I've done my bit and I think I've had enough.
Okay. I'm really sorry to hear you're feeling this way, Sarah, because obviously you have a huge passion for your work in paediatrics. I know you wanted to find out just more information about leaving medicine, but I'm just going to focus on what's currently going on in your work situation, if that's okay. What was work like 5 years ago? Were you as busy as you are now, and were you enjoying it any differently?
Yeah, actually, it makes me happy to think about that. When I moved to this new hospital and I got to know the staff, I really enjoyed it and I enjoyed living in this new place. My personal life was really good. It was great because I was getting to know the local families. I had time to spend with them, and I started to learn, you know, who went to school with each other and what their connections were. So yeah, 5 years ago, it was really great, and I really did think that I had done the right thing.
Oh, that's lovely to hear. So obviously you're talking about how much you really like working with your patients, you like the type of medicine that a paediatrician sees, and you really like helping families. What you are not liking is being busy, being stressed, and being overworked. Is that correct?
Yeah, you're right. That's the hardest part. And I just feel like that's the system, you know. Like, what can we do about the system?
What do you think is different from when you started 5 years ago to now? What's changed?
I'm just so busy. I have so many referrals. You know, I'm really glad that people want to come and see me, but I just can't give them the care that I used to be able to.
So we know that referrals to you in outpatient clinics ultimately means having more inpatients if patients are under your direct care. So with this large burden of referrals just to you, are other doctors seeing the same volume of patients?
No, that's not how it works, because you get a named referral. And so you see them, and I have been able to extend my clinic time a little bit because, you know, everyone could see that I was getting really busy. But we have a system whereby you get the call about the patient if they've been in the clinic. So I do get more calls than other people. And I just don't know that that's fair.
From an outsider looking in, I can see that you're really overworked and you're at the point where you're actually thinking of leaving a career that you absolutely love. So can you think of anything that if you changed it might make your work more enjoyable?
What I really want to be able to do is have more time with my patients. And I don't have time. I have so many referrals, and that just means that I can't give them quality care.
Well, is the solution needing more time or perhaps seeing less people?
Oh, I have to say, if the referrals stopped coming, it would help a lot because it would mean I could just focus on the patients I have.
So what can you do about that? I know that you love seeing new patients, but if you're getting to the stage of burnout and wanting to leave work, then ultimately you're not going to see any patients. If you're going to try and give everything to the patients you currently have, what can you as an individual do at your hospital to stop the amount of referrals coming in specifically to you?
The referral process is one where patients are referred to me with my name on it, and the appointment's then made for me. But you know, there is actually another new paediatrician in town, and as we're talking, I'm just wondering maybe there's a way of sharing some of the workload. I'd have to talk to the hospital about the whole process and the billing and that sort of thing.
That sounds like a really good solution, Sarah. I mean, I know it might be hard to do, but I think you should go away and think about talking to your director about actually implementing this, and maybe we'll have a follow-up appointment in a month or two when you've made some changes. And then if you're still really unhappy in the job, we can talk about what else there is to do in medicine. How does that sound?
Okay, no, I haven't really thought about talking to my director about changing referrals. But honestly, if I think about the fact that this new doctor could probably take some of my patients, and then I wouldn't have to worry so much about the tsunami of patients that just feels like it's overwhelming me every day, that would actually make me quite happy.
So that's just an example. That was actually a true life case that I had with someone. And, you know, we spoke about the referrals. She went away, discussed with her director, and they were distributed evenly, discussed time and boundary settings, and focused on positive aspects of work. Spoke to her a year later and she's still in the same job, absolutely loving it. Over to you, Sarah.
Thank you. Coaching is about asking people what they've learned and what they want to commit to. My invitation for you is to think about what's been going through your mind as you've been listening to us talk today. What sort of things have you taken away that maybe weren't thought about or prioritised beforehand? And what are you going to do about it? Because if not you, then who? If you're interested in knowing more about coaching, my suggestion is to look for people who have established links to the healthcare industry and understand healthcare. And look for people who are offering the kind of coaching that you're after. So today we've talked mostly about professional coaching and career coaching. There are so many different qualifications for coaching and there's not really a gold standard. But if someone is associated with something like the International Coaching Federation, that's really good because they're well recognised and a global institution where if people are accredited, it really does mean they've met a standard. So, I mean, honestly, I have mentors and some great mentors. And in particular, I have a mentor that I've known for 15, 20 years, and I often go to my mentor. But sometimes it's good to get a different perspective. And I think coaching helps you think more broadly and divergently about what your options are. One thing for me to say is that the London Deanery model deliberately matched doctors from one particular specialty with a very different specialty. So they would match GPs with orthopaedic surgeons because we do get into groupthink. And if you have a mentor who's very similar to you, it's pretty likely that they'll say something that you've already thought of. Whereas a coach might help you to think outside the square and think about something differently or in a different way. What do you think, Ash?
I absolutely agree. If you've got a lovely mentoring relationship, then that's gold. So keep the mentoring relationship. Where you might go and get some extra work with a coach, there's a few situations. It's independent, impartial coaching. That's one of the beauties of it, that you're speaking to someone who doesn't know you, who's not in your circles, who doesn't have anything to do with your references. You can, say whatever you like about someone. It's confidential and it's independent, impartial. And you often, so many times I've had appointments where people just need one appointment and they're like, oh, wow, I didn't realize I actually just needed to get a lot of this stuff off my chest. I didn't realize it's actually normal to have blips in your career. It's actually normal to not love your job every minute of the day. I'm fine now. So that's probably the benefit of a coach. When you're working with a mentor, sometimes mentoring relationships, if you're not careful, can almost feel like you're trying to impress a parent. So it's got to be mutual mentoring. You've got to feel comfortable and really safe with what you say to your mentor. If you're in a mentoring relationship and you're just trying to impress them to get onto the training program or for them to help you in your career development, that's great, but that is very different to what a coaching conversation or a coaching environment would be. So I guess one of the main things I wanted to say to the audience today is if you're really not feeling fantastically fulfilled in your career, please know that the answer isn't what I thought it was 10 years ago, and that was, obviously I should leave medicine. There is actually many ways about going about finding a really exciting, interesting, fulfilling career within medicine, and coaching and counselling is what really helps that process.
Another eye-opening presentation from Congress 2021 was given by Associate Professor Peter Connaughton. He's past president of the Australian Faculty of Occupational and Environmental Medicine and on the board of the International Occupational Medicine Collaborative. He consults primarily to the mining industry in Western Australia and carries out academic work through Curtin University and at the University of Notre Dame, Fremantle. As well as this well-honed professional perspective, Peter Connaughton shared an episode experienced early in his career that crystallised the importance of safe and supportive workplaces.
I was about halfway through my training and I had a health condition at that time, and I recall struggling with trying to describe the symptoms of it. I remember thinking, I really must go and see someone about this, but I'm not sure what I'd tell them because I'm not sure how to describe the symptoms. And I remember thinking really strongly that I would need to be able to put the symptoms into words that a doctor would understand and recognise and diagnose. And I spent quite a number of months trying to put the feeling into words, and I could visualise the emergency department up the road, which was only a couple of kilometres away, and thinking, when I go there and they say, what's wrong with you? I'm going to say I don't know, but I'm not quite right. It was never accurately diagnosed by a doctor, and it was never accurately diagnosed by a psychologist. And the reason for that was I never went to a doctor and I never went to a psychologist. It wasn't until about 6 months later that I realised that major sleep disturbance and diurnal variation and lack of interest in studies and change of appetite and loss of weight and not going to lectures, it was only when I came out of that I realised it was an episode of reactive depression from a concussion I had. And it was years later that I reflected on what impact could that have had on patients that I was seeing. I didn't think about that at the time at all. And I think it's really a helpful conversation with doctors and healthcare providers to perhaps reframe some of the discussion in terms of cognitive function. Are you functioning sufficiently well to do your job safely and effectively? Because it impacts patient safety. And by reframing it that way, for a lot of healthcare providers, it changes the way they think about their health and well-being. There may be a presumption that doctors and nurses know when they're sick and that they know what to do and that they know where to go and that they'll do it. And that presumption isn't always correct. Doctors often don't know when they're unwell, and they often know what they should do, but they don't. And a couple of years ago, I was coming back from a college meeting in Sydney, and one of the pilots came out and we got talking. He asked me what I did, and I was passionately sort of talking about the health of healthcare providers and He said, well, in the aviation industry, that's just taken for granted. The health of pilots is central to safety in flying. But the Qantas pilot said to me, the difference, Doc, with us and you is that if we make a mistake, we go in first and you don't. But the thinking needs to be similar. And the investments in safety and health, well-being for pilots, I think, is a lesson that would be well translated to healthcare professionals. The other issues is it's ethically responsible. We have a responsibility to the well-being of junior doctors. We have a responsibility in terms of people's employment and the place they work and the environment that they work in. And there are legal obligations of employers to provide healthy and safe workplaces. Obviously, it's going to improve patient and worker experiences if they're working with happy, healthy healthcare providers. Do you really want your appendix taken out by someone who's really tired or really angry or really hungry? And doctors talk. So money spent on healthcare provider well-being is it's going to assist in keeping and attracting the best workers. Doctors are not going to recommend to junior doctors or their friends to go and work in an environment which they feel is unsafe. So what are the effects of burnout? Reduced work performance and efficiency, loss of interest, loss of job satisfaction, negative attitudes to patients, cynicism, decreased empathy, increased alcohol and drug use, relationship difficulties at home, and increased absenteeism. This is a safety problem. Some of the research findings. Doctors with high stress are 4 times more likely to provide substandard health care. Doctors with high levels of burnout, the figure is between 45 and 63% higher odds of a major medical error in the following 3 months. So this is recognised globally now. The World Health Organization on the 17th of September has the World Patient Safety Day. And you'll see that goal number 2 is reducing work-related stress and burnout. And goal 4 is promoting zero tolerance of violence against healthcare workers. And they refer to the Universal Declaration of Human Rights. And my personal opinion is that there has been an overemphasis on resilience. I'm not discounting that resilience is important. I think it is. But doctors are resilient. They've got high results in their school exams. They've got through 4 or 6 years of university education. They've got through an internship. They've competed. I think they are resilient. And I think to overemphasise resilience is misguided and incomplete. And when you look at it through the lens that occupational physicians look at workplaces, it would be like telling someone who works in a dusty environment to go swimming because it's good for your lungs. It's just missing the mark. I want to talk about something else also, is obviously mental health is a journey. I may be perfectly fine this year, and the year after that I might not be well for 3 months. I might be terrible for 6 months. We can't view individuals as static, and so the systems need to allow for individual variation. The systems need to allow that I might be having a really bad week. There's an assumption when I talk to employers, primarily not in the healthcare, they have a conceptualisation that people with mental health problems can be identified, treated, fixed, and then either removed from the workplace or safely got back to work. But it's not that simple. A proportion of the population is going to be experiencing a mental health challenge at any given time. There is no workplace with no one who's having no mental health problems. Every workplace of significant size will have someone who's struggling at that time. And some of those people will have sought treatment. And some of them will be fortunate enough to get effective treatment. But those who haven't recognised that they have a problem, or haven't sought treatment, or haven't received effective treatment, are still out there working. I'll briefly touch on outcomes of improving the work environment for doctors. And one of the studies is a meta-analysis of 65 international studies looking at the protective and detrimental factors of burnout amongst doctors. And anyone who's worked in a healthcare system would intuitively know some of these answers: workload, organisational structure, flexibility of work arrangements, professional values. Do the values of the organisation match with the individual's values? Organisational factors, how the teams function, and looking at their individual roles. I was involved in a study a few years ago where we looked at about 1,500 fly-in, fly-out resource workers, and it was around the time that there was an enormous focus on FIFO suicide, and we looked at whether it was remote communities, Perth communities, fly-in, fly-out or residential, Indigenous or non-Indigenous. The strongest single predictor was the worker's relationship with their supervisor. And that changed the way that we approached mental health in FIFO people. We changed the focus from resilience to mental health training for supervisors. And I'm very proud and delighted of what the RACP has done in that area in terms of providing supervisor training. I think it's tremendous achievement and advance. In occupational medicine, we often think about the adverse effects of employment. It's really important to focus on the health benefits of good work. And it's good for their health if it's safe and it's rewarding and people like going to good work. So, what would a really good workplace look like? And the college has done this. The college and the Australasian Faculty of Occupational Environmental Medicine, one of our most robust and most successful policies is the health benefits of good work. It's available on the RACP website, and simply, if you had to whittle it down to 3 of the core needs, it talks about autonomy and control, belonging and competence. And in belonging, it talks about feeling valued, respected and supported, and that really gets to the culture of the organisation. You can have as many policies and procedures as you like, but what underlies all of this is the culture of the organisation. And that's the responsibility of leadership and the responsibility also of the workers within the organisation. And this policy on the health benefits of good work has been taken up by hundreds of organisations in Australia and New Zealand. And this is insurance companies and emergency services and a whole range of organisations, including the Reject Shop, who say this is a policy that's endorsed by the College of Physicians and the faculty based on evidence, and it guides what they do. It has been taken up by very few healthcare providers. And finally, it would be remiss not to mention compassion and kindness. In terms of providing care for patients, it's expected that we're compassionate and kind, and the UK document talks about the importance of having compassion and kindness for co-workers. I would encourage you, if you only do one thing in the next couple of weeks, if you're with a colleague and it's quiet and you can sit down and talk to them, say, how are you going? How are you going? Are you okay? It's very powerful. The power of peer support is incredibly important. My colleague, Dr. Roger Lai, who is the occupational physician for Royal Perth Hospital, and his colleagues there set up a fantastic peer support program, and you can look at the feedback in terms of junior doctor reporting on that hospital, and it's spreading to other hospitals. But at the simplest level, I encourage us all to work towards a a future where the health and safety of healthcare providers is just as important as the health and safety of our patients. Thank you.
That was Peter Connaughton ending this episode of Pomegranate Health. I've edited down his presentation, but you can find some of the research on burnout that he referenced in the original linked at our website, racp.edu.au/podcast. It's embedded in the transcript for this episode. Thanks also to Sarah Dalton, Ashe Coxon and Steve Philpot for their contributions. You're always welcome to get in touch and to share the podcast with your colleagues. There's also a comment section at the episode webpage where you can keep the conversation going. For heaps more resources on physician mental health, go to racp.edu.au/fellows/wellbeing. Most importantly, please look after yourself and your colleagues. The Doctors' Health Advisory Service is available 24/7, and so is the RACP's partner for member assistance called Converge International. I've listed their phone numbers in the notes to this episode at racp.edu.au/podcast. Another way to feel you're not alone is to join the RACP online community. It's basically a social and professional networking tool developed just for you. You can log in right now from your mobile by searching for the app called RACP The Rock. I'm Mick Kabazzini, and this podcast was produced on the land of the Gadigal people of the Eora Nation. I pay respect to those storytellers who came before me.